Good morning, everyone. Welcome, bright and early on a Saturday morning. Terrific turnout today, which is no surprise. My name's Ron Fraser. I'm an addiction psychiatrist from McGill University, and I'm the moderator for today's session. I'm going to get things started, and then I'm going to step out of the way and then step back in at the very end. We're very fortunate today to have some very senior people in the field talking to us today about safer supply, opioid agonist therapy, and decriminalization, practical solutions, and effective policies. One of the great things about coming to scientific conferences is we have an opportunity to hear different perspectives on different topics, and obviously this is a fairly controversial topic. So I'm sure the perspectives that are presented will be in complete alignment with some people's views and perhaps not in alignment with other people's views, and that's okay. I'm just asking that we all listen respectively, and then there will be an opportunity to answer questions at the end. As with other sessions, we'll ask people to write their questions on a card, hold them up. We're going to have 4 runners today, which is, I think, a record, collecting them, and then I'll be presenting the questions to our panel. And I suspect, it's a bit unfair, but I suspect that they'll probably be able to stick around at 10:30 after the break for further discussion, because it is quite a topical topic. And with no further ado, I will pass the torch. Welcome and thank you.
Thank you, Ron. I'm Mel Cahan from Toronto, and we have gathered several of my colleagues who are senior experienced addiction physicians who have been involved in some way in the public debate and controversy over safer supply and opiate agonist therapy. So we thought we would all get together and present. Our focus is on practical solutions to the issues. And so I am going to talk about the adverse strategies to reduce the adverse events related to take-home supply of hydromorphone and other safer supply medications. Lisa Bromley is going to talk about strategies to increase treatment retention among patients on opiate agonist therapy. And Lynette Reeb from BC is going to talk about different international models of decriminalization and their pros and cons. Laurie Regenstreif is going to talk about, from Hamilton, is going to talk about her experience as an addiction physician working with vulnerable populations. And finally, David McAvoy is going to, he has lived experience, and he's an outreach worker in Ottawa, and he's going to talk about his perceptions of and experiences in working with people on OIT and safe supply. My conflict of interest statement, first of all, my talk is based on an evidence brief we submitted to Health Canada on safer supply and OIT, and also on an article that was published earlier this year in the Canadian Journal of Addiction. If you want to see the full references and background, you can go to that. It is available as a full PDF. Also, I received an honorarium from Indivior for a presentation on methadone and buprenorphine. Safe supply is also now called prescribed alternatives to the toxic drug supply or public supply of addicted drugs. It is intended for people with opiate use disorder who are at high risk for overdose and who decline or have failed at opiate agonist treatment. Typically, hydromorphone 8 milligram tablets are prescribed, ranging from 10 to 20, 30, 40 tablets a day, usually as take-home. Opiate agonist treatment and other medications are also often prescribed. Many of the programs are funded by SUAP, Health Canada's program, or the Provincial Ministry of Health, so they provide primary care and wraparound mental health and social services. I'm not going to go into this too much. The focus is on take-home hydromorphone, but I think that it's clear that many people have benefited from safe supply. And this is some of the studies, the seminal studies that have looked at it, a case control study of 82 patients in the London Safe Supply Program at 1 year. The patients had fewer ED visits compared to pre-entry into safe supply and also compared to controls not in treatment. A retrospective cohort study, patients in BC who received risk mitigation guidance medications that includes hydromorphone and morphine had lower mortality than those who didn't, and the effect was related to the RMG dose and frequency of dispensation. However, the study did not control for the dose or frequency of dispensation of OAT, and that's a major potential confounding factor for that study. So now on to diversion of take-home hydromorphone tablets. The prevalence of diversion is not really known. Most of the studies done on it are qualitative studies of interviews with safe supply patients, but it appears to be common based on multiple signals, decline in price of hydromorphone tablets in large urban centers, qualitative studies, media reports, reports of seizures by drug enforcement, reports from clinicians, and reports from patients on OAT. And it's not surprising that it's common because other opiate epidemics have also had diversion as a major driver, including the OxyContin crisis of the early 2000s. In a study from BC, for example, 71% of men and 43% of women who died of a prescription overdose did not have an opiate prescription. In other words, they died from diverted opiates. So who uses diverted hydromorphone tablets? And this is an absolutely central question. This is not being formally studied to our knowledge, but based on reports from parents and clinicians and others, tablets are being purchased not just by people who use fentanyl, but by people who don't use illicit opiates regularly, that is youth, people on opioid agonist therapy, and it looks like hydromorphone tablets are appearing in smaller communities in BC, the Yukon, and Northwest Territories. Does coroner's data prove that diversion is harmless? This is one of the things that came up in these public debates. Certainly in 2021, in Ontario, the large majority of people who died of an opiate overdose, it was due to fentanyl. 240 deaths with hydromorphone present, which doesn't mean they died from hydromorphone, and 347 deaths with methadone present. However, diverted hydromorphone can cause other harms besides overdose death, including prescription opiate use disorder, which can be devastating, especially in young people, and transition from oral use to injection use, causing injection-related infections, and also transition from prescription oral opiate use to fentanyl, leading to risk of fentanyl overdose. Now, this has been looked at in earlier epidemics, that is the transition from diverted prescription opiate use to injection use and to heroin or fentanyl use. It hasn't been studied for safer supply opiates, but a very large US national survey of adolescent drug use, they found that use of diverted prescription opiates was strongly associated with later heroin use, compared to youth who didn't use prescription opiates but used other drugs. And two prospective studies of youth in BC had similar findings. That is, those who were using diverted prescription opiates were much more likely to go on to heroin use and to injection use compared to those who were using other drugs. So why would this happen? Why would oral tablet users transition to injection or use or fentanyl use? And some of these studies have been dismissed by safer supply advocates, saying, well, they're pre-fentanyl and pre-safer supply. But it is probable that youth who use diverted hydromorphone will have similar trajectories. That is, they use oral opiates, they develop tolerance, they escalate their dose, then they get withdrawal symptoms. Finally, they find that fentanyl overcomes tolerance, gives them euphoria, gives them more sustained release, relief from withdrawal. And we need to keep in mind that fentanyl, compared to heroin in the early 2000s, fentanyl is less expensive, more readily available, and more potent. So it looks like a perfect kind of storm for transitioning to fentanyl. Now, what about injection-related infections? Take-home dosing versus observed dosing. Take-home doses allow for unsupervised self-injection, which puts people at risk for injection-related infections. This is a study not yet published that was presented last year at CSAM of the London Health Sciences patients who were admitted with injection-related infections. 14 patients were on the Safer Supply program out of an estimated 250 Safer Supply patients. This number, 250, is probably an underestimate because there are also methadone clinics that are prescribing take-home hydromorphone now, so it may be higher than 250, compared to 4 on OAT out of an estimated 2,300 OAT patients. 17 were using diverted Safer Supply tablets. There was also a very major national retrospective study done in France. In France, most of the patients with OUD are on buprenorphine, a smaller number on methadone, and a smaller number, around 1,500 or so at the time of the study, were getting take-home hydromorphone from their family doctor. Morphine from their family doctor. And the rate of bacterial infections requiring hospitalization was 3.5 times higher in the morphine group. Now, of course, this is not a controlled trial, and there were differences between the various groups. In the Naomi trial, after 1 year, that was the randomized trial comparing diacetylmorphine to methadone. All patients received supervised doses. There were no serious infections in the methadone group and 2 in the heroin group. And in the retrospective cohort study of the London SS program, among 82 patients, there were 13, it wasn't hospitalizations, it was hospital visits for infection at 1 year. So a much higher rate among the Safer Supply patients. Other potential harms of take-home Safer Supply medications: people will sell their medications to purchase fentanyl, which is putting them at risk for fentanyl-related harm. And for patients on opiate agonist treatment who are otherwise stable, Safer Supply is very attractive for some of them. Convenience of take-home dosing, of course, but also diversion can be a major source of revenue, and injection of tablets can produce the euphoria that they seek. And clinicians are reporting, again, this is not formally studied, that some of their patients who are transferred to SS have decompensated and done very poorly. So what about strategies to improve safety of Safer Supply? And I'm only going to talk about 2 strategies. One is observed dosing, and the other is combining opiate agonist treatment with Safer Supply. Observed dosing of opiates with the gradual introduction of take-home doses has been an integral part of OAT for decades, for a very, very long time. It has been shown to reduce diversion. It acts as an incentive for patients to reduce high-risk substance use. The new OAT carry guidelines are more flexible and patient-centered than previous guidelines were, for example, British BCCSU in 2023. Diversion, a very extensive review of the literature on OAT concluded that daily observed dosing reduces diversion and is not associated with worse treatment outcomes. And one of the strongest studies on this was conducted in an observational retrospective cohort study done in UK and Scotland in the 90s. They allowed methadone could be prescribed in any way, including take-home doses. After they introduced observed dosing as a mandatory national policy, there was a marked reduction in methadone-related overdose deaths. Treatment retention, that's the big issue. Will patients tolerate having to go to the pharmacy? a randomized trial, for example, group with observed dosing followed by take-home dosing had higher treatment retention than no observed dosing or no take-home dosing. Cochrane review concluded no differences in treatment retention or illicit opiate use between supervised and non-supervised dispensing. Systematic review of IOP programs where all the doses are supervised, patients have to come in 2 or 3 times a day. They have higher treatment retention rates than methadone programs. The Molson program in Vancouver, where hydromorphone tablets are injected on site, the program reports high rates of treatment satisfaction and engagement. So it looks like observed dosing is totally feasible in safer supply programs. What about opiate agonist treatment combined with observed safer supply medication? The idea is that optimal doses of OAT will reduce the need for large hydromorphone doses, thus reducing diversion and unsupervised injection. And in fact, methadone 100 milligrams is equivalent to 28 milligram tablets of hydromorphone. There is strong evidence, of course, for the effectiveness of OAT, and opiate agonist medications are a strong background for, backbone, I guess you might call it, for people on hydromorphone because it provides a constant and sustained relief of withdrawal symptoms and cravings. There was a retrospective cohort study, Selfridge, I think that was BC in 2022, patients who were on continuous opiate agonist therapy and safer supply actually had substantially higher treatment retention rates than patients on hydromorphone alone. And this combination appears to be acceptable to patients. An observational study from Ontario found that 62% of safer supply patients, sorry, I have a cough from my grandson, were also on OAT. So that is basically a very quick review of the evidence and suggestions for strategies. Now I'm going to turn it over to Lynette, who will talk about decriminalization.
Good morning. I'm just waiting for him to put up my talk. Great. All right. I have no affiliation with pharmaceutical companies, and so no disclosures. So the objectives here, I'm going to outline the Portuguese model of decriminalization within a recovery-oriented system of care, and review decriminalization approaches in Oregon, BC, and their recent changes, and compare that to the Portuguese model. After my talk, they're going to go back to talking about safe supply again. All right, so just so we're all on the same page, I just wanted to review the legal frameworks that we have in Canada of criminalization, medicalization, decriminalization, and legalization. So criminalization, where it's illegal to produce, distribute, sell, advertise, possess, or use, so something like methamphetamine in all provinces but BC. Medicalization would be the exemption to manufacture, produce and sell, and if you receive it on prescription from a doctor or in some cases a nurse. So examples of that would be certain opioids that we have in Canada. Decriminalization is allowing the production and sale still to be illegal, but possession for personal use is not a criminal offense. And legalization is legal to produce, distribute, sell, advertise, possess, and use, and that's things like alcohol, tobacco, and now cannabis in Canada. All right, so to dive a little bit deeper into decriminalization, I mean, these are very, obviously each of these topics you can spend a lot of time on, but just an overview of the purpose of decriminalization. The concept is to reduce or eliminate consequences of possession and substance use for personal use while continuing to prosecute dealers and producers. So the hope for outcomes there is to treat addiction as a mental health issue instead of a crime, to reduce incarcerations and costs associated with use, and to reduce stigma, and thus hopefully helping people enter society and maybe treatment and things. So in the Portuguese model, which I've been exposed to over many years. I lectured at one point with Dr. João Galau at a conference, and he invited me to come to Portugal and spend time with him personally and to see the model. So I did that last June, and I was able to go. And so he spent hours with me, and I could drill him about different questions I had and what was working, what wasn't working. So I just wanted to share that today, including how the program came to be, and then we'll talk about the differences within Oregon's program and then BC's program, okay? So just to give you the bottom line on what Dr. Galau, his perspective on this, is that decriminalization is used as the hook to bring people in for face-to-face assessment in the Portuguese model, which helps people into a recovery-oriented system of care with the goal of social reintegration. So that is, in a nutshell, the Portuguese model. Decriminalization, not linked to assessment and to recovery and care, is not the Portuguese model and is not going to probably get the outcomes that are desired from the when people talk about the benefits of decriminalization and put up the Portuguese model. So he says that decriminalization unlinked, which is what happened in the first year or two of their program, when they didn't have everything set up to assess and treat people, they actually increased drug overdoses and increased crime and in their country. So they went the opposite direction. So once they had the system in place that could receive and treat people, that's when things worked out better. So Dr. Nuno Capaz runs it's translated as the Drug Dissuasion Committee in Lisbon. They have them in every major city. And this is the committee that people are brought into. So let's just go back and do a little bit of history. So in the year 2000, drug possession, they had a national vote, and they determined that drug possession for personal use was then changed from a criminal offense to an administrative offense in Portugal. And why they did that is they had the highest overdose rate in all of Europe. There's a whole history behind that we don't have time to go into. But, you know, they had an open drug scene like Vancouver's downtown east side, and they had lots and lots of overdoses. And so people in all sectors of society were dying, and it became like a national emergency like we have here. So that's why they had a vote and they implemented. So what they implemented was that the police, that public use of drugs still was illegal. So drugs that are found on a person by officers, the drugs are confiscated and destroyed. The person caught with the drug is brought by police in front of a committee for assessment, or an appointment is made for them to show up to do so. And the person is met with usually by a social worker and a psychologist who will do an initial assessment, and then it goes to another committee that consists of a lawyer, sometimes a sociologist, sometimes someone from law enforcement, and they're offered resources based on their modifiable risk factors at no cost to the patient or the person coming in. So they're offered housing, mental and physical health care, drug and alcohol treatment, vocational rehabilitation, and that includes that employers were incentivized. The government would pay minimum wage or 50% of the wage, whichever was needed, for the first 6 months that they would employ a person. So you went from the least likely to be employed to the most likely to be employed. So that was the integrated recovery model that was used. If the help was declined, the person could get a warning. If it was declined numerous times when they came in, you might get a small task, like you have to show up to your doctor's office because you've been off your HIV meds for a long time. So you don't have to take your meds, but you have to show that you get there, or to an employment agency or something like that. For some people who don't want to do something like that, it might be clean graffiti, or it might be a 35 euro fine, something small. And tasks would, so it was small stick, big carrot to come in. For treatment, what they offered in this model was, and I visited all of these different aspects of the model, or almost all of them. Residential 10-day detoxification stabilization for those who want to get off illicit drugs and alcohol. I visited Dr. Anna Croca and toured their detoxification unit run by psychiatry. They could be transferred then to a sober living community or therapeutic community, and that's similar to our recovery houses but with more resources typically for 3 to 4 months. You can stay longer. There are 6-month stays. There are therapeutic communities that are you could stay for several years if you wish. There's outpatient care. Clinics are assigned depending on their primary issue. You might be assigned an addiction medicine doc or a social worker or a psychologist depending on your primary issue, and there'd be a whole team around you. They also pay for your bus fare there. They pay for childcare if you need that while you're in session. There's both group and one-to-one sessions. Methadone and buprenorphine in the form of Suboxone were obtained from the treatment centers. They don't distribute it in pharmacies, so we're way ahead of them in that regard. We have much more access to OAT. They do have a methadone bus that they send out for people, and that's almost like their safe supply, their harm reduction, because you don't have to agree to be abstinent from any drugs or even have that as a goal, but they're trying to keep people's tolerance high so that they don't overdose on the heroin that they're using, let's say. There hasn't been a lot of fentanyl penetration yet, but on heroin and other things, so they don't overdose. And the bus has a lot of resources on it. There's nurses, social workers, psychologists who help to take care of physical and housing needs and things like that and link you with things. And then they don't have any slow-release oral morphine in their country, so again, we have that as a leg up to offer as an option, and there's no supervised injection of OAT there, so no IOT there when I was there last year. And they don't have safe supply in our form, like take-home hydromorphone or other drugs. So this was an example of a methadone bus that we went out in. So what do they do for harm reduction? We do outreach with naloxone and water and rigs and things, and I went out with the outreach nurses into the hillsides and talked to people and got to see that, just like I was all day with Nuno Capaz in the Drug Dissuasion Committee, and I got to talk to the people. They invited me in. They were very happy to have me sit in on the sessions, which were fascinating, and it was a really great experience. So they do have supervised consumption site. They just opened 2 years prior to me getting there, and there were 200 people that they had seen, about 35 overdoses they'd resuscitated, none from inhalation, so inhalation seemed to be a much safer route, as we know. They do have an inhalation room and then their injection room. I saw no rivalry between harm reduction approaches and treatment approaches, so there wasn't this kind of tension and animosity that sometimes we see here. One of the things I learned was once they opened the supervised consumption site, there seemed to be a fairly low level of transition of people from that site into treatment. And the staff said it's because people got so comfortable there. It was almost like a party when they show up. So there wasn't this, they kind of lost the wind behind their sail to go into treatment, especially if they're unhoused. So what they did is they just really put a big push on housing. And they use a housing first model there where no more than 5% of any one building can have people from their program in it, so that they're really integrated with the rest of society. That's worked really well. And they offer you 2 or 3 homes to go to right away. They work with people who are really street entrenched, and you get to pick the home and then stay there, and they put resources into you, which they slowly pull back as you stabilize. So it's worked extremely well, and I'll give you some stats on that in a sec. So then combined, so what are the outcomes? So combined and integrated, these steps have been highly effective. So 80% of those who have a substance use disorder accept treatment on that first assessment. 90% of those who are placed in housing stay housed at 1 year. 50% of those people are working within a year. They have lower rates of HIV, incarceration, houselessness, and addiction since they started these programs. And participant satisfaction is 85% plus, even after that first assessment when the police have brought them in and no one wants to go. So this shows you that when they're faced with healthcare providers who care, who have this, and who can connect with the people, who are good at their job, there's this incredible uptake. Portugal went from the highest overdose rate to the lowest, and currently their rate is 0.7 per 100,000, which is 1 to 2% of British Columbia. So what are some of the cracks in the system? So in 2008, the market crashed. So in 2012, the government reduced spending on addiction services, and 60% of it they privatized. So this really broke up the system that was working extremely well. They no longer saw open drug scene and everything seemed handled. So they were like, oh, we can pull back all our money. Well, that wasn't working so well. So rates of addiction and people experiencing homelessness and drug poisoning all rose. The new government, though, now has reinstated Dr. Galau as head of umbrella of housing, social services, and physical and mental health. And so he can move people and resources between those. So Dr. Galau says we actually in Canada have lots of resources. We just have it very siloed. It's very hard to move between resources and people fall through the cracks all the time. So we need much better integration. Also, fentanyl has really not hit Europe. They had not had any fentanyl overdoses. And some people criticized and said, well, it won't work here, the Portuguese model, because, you know, there's no fentanyl there. That's why it works. I don't buy into that at all because it's the structure of treatment. It doesn't matter the substance. Helping getting people into a recovery-oriented system of care and dealing with their Maslow's hierarchy of needs and meeting people with where they're at and doing a housing first model. We even know in Canada that works well. We've had big studies on the housing first model, which then were not funded by any government, but we've shown that it's highly, highly effective. So, Mark, why have they not had fentanyl there? And, you know, so market forces are low due to low user rates, so there's low profit for dealers coming in. Also, there's very harsh sentencing for dealers or traffickers, and they put a lot of money into really buttressing their police force for traffickers. The proximity from China and Mexico, which were initially the major importers, we're closer, so we had more of it. That's part of it, and we have very leaky borders. And we don't know what will happen if and when fentanyl does hit their country, but I think they'll be vastly better prepared because they have this system in place to help and treat. So let's shift to Oregon. So residents of Oregon voted on Measure 110 in 2020 to decriminalize possession of small amounts of drugs for personal use, and they enacted this in 2021. They changed drug possession from a felony or misdemeanor to a Class C offense. Just like in Portugal, they changed it from a criminal offense to an administrative offense. So the police still had power to bring you in against your will. So, but here in Oregon, the police no longer brought you in. What they did is the police could issue a ticket for up to $100. And in order to get that ticket expunged, you needed to call a helpline. So they issued, in 3 years, 7,600 violations, tickets, and only 200 people called that helpline, and vastly fewer actually followed through with any of the resources on the helpline. So they did not do the Portuguese model of the face-to-face assessment and offering all those resources. What they would do is outline resources, and then the person had to call themselves and get hooked up and things. So actually, treatment initiation dropped after they initiated decriminalization. So in Oregon, overdose deaths in Oregon increased 52% in the first year, whereas it was just 14% in the US as a whole. And since 2020, it went up 1,500%. Police stopped arresting people with open drug use due to backlash of the public and of users on the street when they try to take drugs, because it was still illegal to use on the street, but they had lots of backlash because now of the law being passed, people felt they had the right to use anywhere, so the police just backed off. So open drug use really spread, violent crime increased, streets and parks and public transit became unsafe, and businesses closed. So advocates said that that was the result of fentanyl influx hitting the street. People who were detractors said it's all due to decriminalization. Likely it's due to both. But why did fentanyl hit the street so hard right after decriminalization? When you put a level of so much that you can carry, people want to increase their drug potency so you can carry a smaller amount and not get caught or arrested. Also, you have low-level drug running that can increase and carrying small amounts of potent opioids. So they may have inadvertently worsened a problem that they hadn't thought, you know. So this is, sometimes you have good you mean well and it looks like you're going to do the right thing, but you can have some consequences. So I don't think that we should shy away from looking at what those consequences are so that we can mitigate those consequences and not throw the baby out with the bathwater. So what happened was in March of 2024, decriminalization was repealed and modified in Bill 4002, and it went into effect this September 1st. Those caught using publicly now will have their drugs seized, so they gave more force to the police. Even though they could always do that, they really told police to now, please do that. And if you're caught with public use, law enforcement must place the person with a treatment provider or in front of a judge for probation, and repeat offenders eventually can get up to 6 months of sentencing, and that sentencing can be to go to a drug and alcohol treatment facility or other means. If you're very violent, it might be actual incarceration. And they set aside $211 million for court-mandated programs and voluntary drug and alcohol treatment programs. So that's where Oregon's at. So let's talk about BC. So in January of 2023, the federal government enacted a 3-year exemption to the Controlled Drugs and Substances Act so that British Columbia could decriminalize possession of small amounts of drugs for personal use. It was no vote, unlike in Oregon and Portugal. So the public did not get to vote on that. It just was put through. No longer was it a criminal offense to possess up to a combined weight of 2.5 grams of a variety of substances for personal use in those 18 and over. So that included heroin, fentanyl, cocaine, crystal meth, MDMA. There was about 23 things on the list, but those are the top ones. No drugs will be confiscated, even with public use. So that was a big difference from Oregon and Portugal. Except there were a few exceptions. If you were in a daycare, if you were in an airport, if you were in a police car, if you were in a motor vehicle, you couldn't have it there. No ticket or call line was given. Instead, they had the idea that the police, if they wanted, could give out a pamphlet with a QR code on it that you could scan that would tell you what resources were. So you had to have a phone, and you had to have a smartphone. You had to know how to, use a QR code. And then you had to call the resource. So it's very, very far from a face-to-face assessment who can then pair you with resources and help you get there to the resource on that day. So BC really missed out on the crucial element of the Portuguese model and removed both carrot and stick and hoped that the word decriminalization would help. Now, I'm sure it helps to not criminalize, as none of us want, to criminalize people who have a health problem, who use substances. But in this way, they really did not adopt what was an evidence-based model that came out of Portugal. So our open drug scene has increased. Impacts are seen on the streets, in parks, public transit, businesses. There's a lot of staff exposure in hospitals without recourse. People are using in their hospital beds. Nurses, doctors, staff, cleaning staff exposed to all this. So the BC government introduced an amendment to ban illicit drug use in some public places like hospitals, businesses, transit, parks, and allow law enforcement to confiscate any drugs found in public. So moving a little bit closer to the Portuguese model. So drug possession for personal use was still allowed in private homes, shelters, outreach addiction settings, overdose prevention, and drug checking services. And challenges were brought then to the BC Supreme Court of Appeal by the Harm Reduction Nurses Association to block these amendments, and the judge decided with the nurses. So our Premier Eby, NDP, and the BC government asked Prime Minister Justin Trudeau to pass a measure in BC to exempt public spaces from decriminalization, and this was granted May 7th of this year. And Premier Eby, just to give you a clip of his view on this, is that British Columbians overwhelmingly agree addiction is a health matter. At the same time, they're also concerned about open drug use in public spaces, especially near where kids play. Premier Eby said that in a news release. So he said the new restrictions will bring the rules in line with those for smoking, drinking, and cannabis use. Because prior to that, you couldn't drink a beer on the street, but you could inject meth, So, just to give a little balance to the situation. It was getting pretty out of hand. So the questions that we have not answered effectively yet, and yet we've rolled this whole policy out, and really, I feel like we haven't really done good research on some of the potential harms, and thus you can't mitigate those harms if you don't look at them. So we have not looked at the perception of harm, especially among youth. We know when their perception of harm goes down, with legalization and decriminalization of other substances, usually use goes up. Drug availability, pricing on the street, drug use, drug potency, diversion, overdose poisoning, treatment readiness and treatment entry, which had dropped in Oregon, stabilization for those in treatment and recovery, organized crime, which typically when you decriminalize in an area, it can go up, like it did in Colorado when they decriminalized cannabis. Actually, organized crime actually really increased in the state, not decreased. So low-level drug dealing, honeypot effect, where people come so they can use their drug tourism, where people come from out of the area to come just to visit so they can party, and cost of implementation of what we did versus the Portuguese model versus other recovery-oriented models. So we really haven't answered these questions yet. So in summary, the lessons learned from Portugal, Oregon, and BC is that decriminalization alone may decrease incarceration rates for simple possession, which I think is a very good thing. But decriminalization without assessment and linkage to other services may lower consequences of use and incentives to go to treatment, and increase poisoning and public disorder and attract organized crime, if you base it on the Oregon and Portuguese experience. Assessment with wraparound, fully funded services are vital, including treatment, medical care, housing, vocational rehab, and employer incentivization to encourage social reintegration. And we can modify BC's version of decriminalization better to integrate the Portuguese model evidence and approach to adapt it for the Canadian context. And if we're thinking of rolling out decriminalization in other places, I think if we can make it closer to the Portuguese model, that would be of benefit. Okay, thank you very much.
Hi there, thanks. Lynette promised that I would get back to talking about safer supply, and I'm going to do anything but. That's a joke. So I'm going to talk about, I guess, you know, one of the reasons, or that I understand about how safer supply sort of came to being, is that OAT doesn't work, that it doesn't work well enough. And actually, that's true, that OAT does not work well enough. So I'm going to talk about some strategies to make OAT work better. And this is I'm going to go take it from a very a treatment paradigm, not kind of a prescribed alternatives paradigm. This is very I guess, founded in the principles of safety and effectiveness. And I guess I will go out there, stand up there and say that the current model that we have for take-home tablets does not meet the standards of safety and effectiveness of a medical treatment yet. So these are all, what I'm going to talk about is interventions that we can all do, and probably many, if not most of us, are doing some of these things already, sort of very grounded in a safety and effectiveness treatment model. So in terms of my disclosures, I do have a few, mainly that I have worked with Brand-Aid and Medicom in terms of for developing educational materials and for an advisory board related to Indivior. So what I'm going to do is talk about, we all know that OAT is life-saving, and I'm just going to touch on some of the data about that. Talk about some of the problems and the barriers of why the medication only works if you take it. So why aren't people taking their OAT? And then some ideas, practical ideas about what we can do to sort of improve retention. So we all know that OAT is life-saving. And in fact, I mean, methadone has been around since, what, 1963? So what, 60 years? The evidence of benefit for methadone, because it's so old, would fill this room. Buprenorphine has also been around for at least 25, 30 years, right? So there's mountains of evidence that these OAT medications are life-saving. And so I just want to point to a particular BC study where looked at, I guess, over 20 years of OAT and sort of what is the standardized mortality ratio? So what is the expected level of death in a sort of an average population? What is the level of death on OAT versus off OAT? So people who have opioid use disorder have a higher mortality rate. That's a fact. And so on OAT, their risk of dying was substantially lower than off OAT during this study period. And actually, when fentanyl came on the scene, OAT was even more protective, that their standardized mortality rate actually was less, less likely to die on OAT than off OAT when fentanyl was in the mix. But we all know, we all struggle with dropout rates of people not coming to take their medication. So, you know, if we're lucky, 6 months, retention at 6 months is about 50%. But so why? Well, I mean, so there's program factors and then dosing factors. And so in program factors, I think, you know, up until the pandemic, and I'm speaking because I have a lot of experience in the Ontario context, that we had being on methadone was really restrictive, and there was very restrictive guidance that the college would come and be all in your business, and so, you know, it was hard to get carries. And there was this chill that, oh yeah, methadone was a special thing. So if you're in a hospital, I mean, at the Ottawa Hospital, up until, you know, recently in the last 5 or 6 years, there was no one. It was really hard to get someone who knew how to prescribe methadone in the hospital, right? Primary care, people, you know, there's still the uptake of treating this chronic kind of recurring disorder with a life-saving medication. I mean, primary care doctors just don't feel equipped to do that. So methadone and buprenorphine are hard to get. And people say, well, it's a lot easier to call my dealer to relieve my withdrawal than to go wait in the emergency room or, you know, try to get to a clinic. You know, so we've made methadone in particular and buprenorphine as well. Like, it's hard to get. And, you know, the people want high quality programs, right, with the wraparound services. And so methadone care, I mean, so we heard yesterday through CRISM that, you know, I guess this is sort of a little bit against what we heard in the CRISM guideline presentation the other day about, well, you know, the psychosocial care doesn't really matter, that it's just the medication that is life-saving. I guess what I take away from that is that if you don't have kind of all the wraparound services, that's not a reason that you should not prescribe a life-saving medication. But I think there are some participants who want that kind of wraparound attention, right? And they have a lot of needs, right? Housing, ID, healthcare, et cetera. So in Ontario anyway, there's this siloing of OAT clinics from primary care, and I think that that's unfortunate, and, you know, I'd love to see the shift and change about that. And sometimes, you know, there's some perverse incentive of, you know, making people come for way more urine drug screening than is really needed. So, you know, methadone is hard to get. There's a lot of barriers. It's restrictive. It's siloed. You know, and we've heard from Mel that this graduated level of take-home doses or carries, right? Initially, the observed dosing is necessary to prevent methadone-related deaths. And you know, Mel referred to all of us as senior OAT, you know, prescribers, and so I guess I have the gray hairs to show that. But I mean, I was around in the 1990s when there was a crisis of methadone overdose deaths. Like, people were dying from methadone overdoses, both within programs and from diverted methadone. I mean, I remember that. I remember attending, you know, presentation by the Toronto coroner about there's alarm being raised about this. So observed dosing is necessary initially, but I think sometimes that, you know, and maybe from the legacy of the Ontario College involvement, that sort of observed dosing has been continued longer than necessary. And we've learned from the pandemic, the pandemic carries guidance that people do okay with more, you know, more permissive take-home doses. Mind you, when Tara Gomes looked at that, quite a lot of people actually stayed on daily dosing. So just to bear that in mind. So, you know, like, I guess just in terms of that tension between take-home observed dosing is protective both to the person themselves and the public, but it needs to be sort of the right touch about when they're ready, that take-home doses can improve retention. And so that's program factors. Dosing factors, so 30 milligrams of methadone. So for the longest time, that was the maximum dose that was sort of considered okay to prescribe. And you know, when fentanyl came around, my patients told me, I don't feel a thing from 30 milligrams. They almost literally sneeze at 30 milligrams, right? So I think we need to really recognize that fentanyl is so much more potent and people's tolerances are so much higher that we really need to relook at how we dose methadone. And, you know, it would be, it's hard science to do, but I think it's really necessary to try to get people comfortable. I mean, yesterday in the Medify emergency, you know, using OAT in the ED, I heard Liz Schuldeis, she's here to talk about, we need to get people comfortable really fast, like right away. They don't have time to wait a week or 2 weeks to start to feel comfortable from their withdrawal symptoms. So, and, you know, the more fentanyl they use, you know, the missed doses, if they miss a dose, then, oh my gosh, then we can't go up and we have to go back to 30 milligrams, I really think that we have to kind of look at that a bit with a different lens. And, you know, I want to also anticipate a comment in the CRISM guideline presentation. They talked about in the first month of methadone treatment that mortality is increased, and certainly before fentanyl, that was definitely the case, that the first 2 weeks of treatment were considered a really risky time, that actually that baseline mortality rate actually went up in the first 2 weeks of treatment. Now, the thing about, and that was very evidence-based, what in the studies that they looked at in CRISM for that increased 1 month mortality rate, they did not look at what was the opioids that people were using. So I'd be really interested to sort of drill down, maybe in the next few years we'll get some more information about, based on, you know, is there increased mortality in the first 2 to 4 weeks in fentanyl users, right, versus heroin or prescription opioid users. So I just want to, what I'm about to say, I'm going to describe some more aggressive titration schedules for methadone. And so I just want to kind of put that out as a caveat that, you know, we do know that historically in the first 2 to 4 weeks, the mortality from methadone initiation is higher, but I think we need to kind of, maybe there's some nuance there. Personally, I believe there is some nuance there. Okay, so what can we do? So we can co-prescribe SROM with methadone, for example. And initially, so Mel and myself and Lori and Jennifer Wyman and who am I missing? Anyway, the Medify group got together and put together methadone for fentanyl guidelines. And this was sort of based on our collective experiences and as much evidence as we could find. And so we recommended that people can co-prescribe SROM, so slow-release oral morphine, with methadone in the first, when they're initiating methadone. And there was a couple of reasons for this. So methadone, as you know, is long-acting. Half of yesterday's dose is here today. So even if I give you 30 milligrams every day for 3 days, well, the levels in your system keep on going up, even with 30 milligrams, still a steady dose. But morphine washes out, morphine is metabolized more quickly. Pretty much after almost 24 hours, a lot of it is gone, right? So there's not the dose stacking that happens as much with morphine as with methadone. So that was one thing that we sort of given them a little sort of turbo boost in those first few days, 2 weeks. And I think, honestly, they're listening to my patients, my clients, it's like, well, they still want that feeling. They want that subjective feeling of something. And that is something that that sort of gives them a subjective sensation that is just a little bit more palatable. And with the observed, it can be observed with methadone, right? So this is all observed dosing, so it doesn't run the risk of diversion or of injection use of oral preparations that you would run into with take-home tablets. Okay. And so, you know, what's their evidence? I mean, and the evidence that we took from this is unfortunately was unpublished, but it was sort of a standard recommendation from Saskatchewan. standalone slow-release oral morphine. So we heard yesterday now, or not, on Thursday, that that's considered full second-line treatment, so only slow-release oral morphine. And some people just feel subjectively better on slow-release oral morphine. They prefer it. So that is something that is now endorsed by CRISM. Now, here's where I think is the exciting parts. For the longest time, 30 milligrams was the maximum. Recently, the BCCSU allowed between 30 to 40 milligrams as a starting dose for people who were experienced with methadone and who were fentanyl tolerant. So, I mean, I'll just, by the way, now every single person who uses fentanyl every day, I start them at 40 milligrams. I work in an inpatient setting, and this is a potential, for sort of an opportunity for more rapid titration. And we're sort of seeing that in this sort of more controlled, monitored setting, that you can give 30 or 40 milligrams and give extra doses, 10 milligram PRN doses, as long as they're not sedated. There's a nursing assessment, and you can get someone to 60 milligrams on day one, and then kind of up from there. So, there's case reports and case series talking about this. And I think that, for those of you who may work in a hospital, that's an opportunity to get someone to a higher methadone dose safely when you have the chance. Now, this is a study that I'm very excited about, and we really need to expand this kind of study and figure out who are the candidates for this. Because, so Scott Steiger in San Francisco was basically, sounds like he just got impatient. It's like, God damn it, let's just get people up to a therapeutic dose. As quickly as we can. And so he went, now what was his dosing? 40, 60, 80. So day one, 40 milligrams. He worked in a public health methadone OAT clinic. So day one, fentanyl tolerant, and there were exclusion criteria were sort of what we'd expect, sort of comorbidities, older age, lower tolerance. But for people who were using fentanyl every day, they got 40 milligrams on day one. Day two, they got 60 milligrams. Day three, they got 80 milligrams. And it was an assessment, it was a staff administering the methadone who'd sort of, hey, how's it going? How are you feeling? So this was kind of with some amount of assessment prior to administering these higher doses. So, but basically what he found that people could get up to 90 milligrams on an average of 90 milligrams by the end of the first week. And I had the opportunity to sort of attend a webinar that he gave, and he said the patients loved it. And people were coming to his clinic for this accelerated dosing schedule because people were getting comfortable faster. And his team was very careful in searching for deaths. Right? I mean, what did happen? The people didn't show up, did they all die? Because they all died of methadone toxicity. And so with his methodology, it's persuasive that they searched all the death records. So in his cohort, there were no deaths associated. I don't think there were any deaths, actually. And that was his protocol. So, I mean, do I recommend that you go and do this at home? I don't know. But it sort of shows, to me, it's sort of feasibility. And, SUAP, they funded safer supply programs for millions and millions of dollars. And it's like, what about a call for proposals to do a study like this and, to try to determine who it's safe to do this for? Anyway, if I don't know, I'm not the funder, I'm not Health Canada, but I just want to highlight this as this was shown to be feasible. How am I doing? I'm gonna just, chop. So we've all heard about microdosing, macrodosing buprenorphine, get comfortable really quickly. Paramedics there's medical directives for paramedics to administer buprenorphine at the scene of an overdose. So if the patient wants, hey, are you interested in some Suboxone? So that can be administered at the scene. They don't have to go to another clinic. There's a little headline, we're starting this in Ottawa now. We're sort of being much more, using much more kind of aggressive with buprenorphine XR, the injectable subcutaneous buprenorphine, more often maintaining people at 300, cold shots, right? It's just someone who is tolerant, Forget all the, test dose, just give them the shot. And then over 24 hours, they sort of do an auto microinduction. Briefly, we've talked about supervised injectable opioid agonist treatment. And this is sort of I bring this up because, this is inaccessible in Canada, but it is sort of the theoretical foundation for the tablet programs, right? Supposed to be for treatment for refractory patients who are still using despite methadone. It's effective, it's cost effective. It's used in Europe, except Portugal. Naomi and Salome, I want to say that, so in order to be recruited for the Naomi trial, you had to have failed methadone 3 times. So this is defined as methadone has failed in these people. Methadone does not work in these participants recruited. And what do you know, when they were randomized to optimize methadone, to methadone only, no diacetylmorphine, what do you know? They actually did very well. They retained, whereas they had not been retained before. So I wanted to make that point. So I'm going to end there. OAT is life-saving, retention is poor, and there's things that we can do tomorrow to improve retention and client satisfaction. Okay, thanks.
Okay, yeah, I'll just be a little bit more, oops, sorry. I'm actually Lori Regenstreef. I'm going to really just touch on a couple of things that are really important to me and really important to the communities that I'm working in. And that's really about vulnerable groups, and 2 in particular that I consider quite a large group that nobody's looking at, and the fact that they're canaries in the coal mine when it comes to the increasing presence of more and more prescription opioids in particular in the community, in their communities, or in their cohorts. So how do I advance that? There we go. Financial disclosures, I've received honoraria from both Indivior and Master Clinician Alliance for doing teaching sessions, giving talks, and for teaching injection techniques with one of the products. I also am receiving a research stipend for a SUBLOCADE long-term 4-year observational outcome study. Other than that, I have no other industrial conflicts of interest. I just want to make a point that what we tend to see, I'm guessing the majority of people here are urban, that we see urban populations. We see an urban drug culture, urban drug users, people who identify as people who use drugs, who live in urban settings, or possibly, at least in Ontario, semi-urban settings. And that in the world of harm reduction, one size does not fit all. So what we think may be fitting and appropriate may actually be really inappropriate and causing harm elsewhere, but we're not hearing about it. So I sort of have my finger on a couple of little pulses, so to speak. Because, in the populations that we're seeing, they may be preferring opioids and fentanyl, and they may be more involved in injection drugs. There may be more complicated, complex, and sophisticated peer networks. And not everybody is in a situation where they need or even want what we would define as clean drugs as opposed to an alternate to the toxic drug supply. Some communities, and this, I'm speaking more on the part of, I'll give you a bit of a background. I work a lot in the Northwest Territories. I've now probably worked with 8 to 10 small communities and 3 health regions. So we're working on drug use policies or drug policies for those regions. Drug and alcohol policies. And what I find is, in terms of substances, many of these communities, they don't struggle with IV drug use or even opioids. So anything we apply nationally, we have to keep in mind that it's got to fit some of these usually highly, in proportion, highly indigenous communities as well. They have strengths that are unrecognized. So they have very strong social bonds and family bonds that we often never see in the city when we're working with people who use drugs. They're often seeking recovery in a culturally appropriate and lifestyle appropriate setting. So when we think of harm reduction, only some of our interventions, or what we consider to be good interventions, are even appropriate up there. And I say up there because we're talking north of where all of the provinces end and the Northwest Territories begins. And autonomy is also really important to them. They don't always want to be sending people out to rehab to Nanaimo or to Edmonton or Toronto. They really want to be able to build their own solutions for substance use disorders. So that's just the background of one of the settings I work with. All these populations, though, benefit from substance use education, harm reduction education, naloxone kits, and of course, screening, brief intervention, and referral to treatment. There's nobody who doesn't benefit from those approaches. But the question is really, how might tablet programs be harming young youth in northern communities, and really northern communities which have a very low average age anyway. They're young communities with a lot of young adults. Well, they're cheap, they're easy, and they're safe. At least that is how they're perceived. What's happening that we're mainly seeing is that, the other population that I work with is youth in detention, so youth in custody. So I work with youth in a closed and an open, 2 closed and 1 open custody setting in Hamilton. I've also worked with young adults at the North Slave Correctional Center. And what I see from them is like the tip, the front. They're like, again, canaries. They're exposed, they're young, they're often very naive about opioids. They don't even know sometimes that, for example, a dilaudid 8 tablet is an opioid. They just know it as a drug. And the things that I hear from them are concerning. So these are quotes. I'm not sure if there's no animations, but when I ask them, I take a substance use history on all intakes in youth detention, and what I hear are things like, I'll list all the medications or drugs they could possibly use, alcohol, cannabis, and so on. Cannabis use is quite striking. I'm seeing 15-year-olds using 7 to 10 grams of cannabis a day by themselves. But when I ask them, when they endorse that they do receive or find or have or used D8s, or they call them dillies sometimes, and this is now very common. So my nurses and I have figured out that almost every single week for the last 6 months, we've seen at least one intake of a boy between the ages of 14 and 19 who's been accessing dilaudid 8 tablets in the communities, and this is in Ontario. The answers I'll get are things like from the van in St. Catharines. So that would be a patient who, a young man who went to the van, told them that he'd had multiple overdoses from fentanyl because someone told him that's what you say, and he got the dilaudid 8 tablets. I hear from a clinic in Burlington. I walked into the clinic because I was having trouble with oxys, and I walked in, saw a guy on a video screen, and he gave me D8s. That story gets even more interesting, but I'm not going to get into it. But that same guy said, when I went into withdrawal in the other correctional facility before I came here, the doctor offered to put me back on the safe supply program. That I found really shocking. This is a 15-year-old boy. I asked one boy who said he'd been using D8s quite regularly with his friend. I asked him if he'd ever overdosed on them. He said, well, I didn't, but my friend did. And I said, well, what happened? And he said, well, my mom gave him Narcan. So the whole normalization of these experiences is concerning. And another young man who was involved in drug trade himself, and also very young, said that he liked them because they helped him sleep at night. And what he did was he got the fentanyl from his friends who were dealers and traded them for the hydromorphone tablets, which is a little bit of a reverse. So I don't think I'll go into the case, but this is the 16-year-old who was getting the hydromorphone tablets from the walk-in OAT clinic where he saw someone on a video. But it was funny because he did say to me at the end, well, I had to taper myself off, so I used oxys to taper myself off the hydromorphone tablets. And I said, why did you do that? And he said, well, you can't be on that stuff forever, can you? I watched Dope Sick. And I said to him, oh, and I said, well, did you know who makes dilaudid 8s, the name brand? He said, no. Purdue! So it was a funny moment because we just met. So youth in the justice system, to summarize, are vulnerable. They're a diverse and high-risk population who are exposed to multiple substances, but not necessarily anything consistently. So the likelihood of finding a lot of opioid tolerance in this group is small. They're often very high risk for lots of other reasons. They're from very unstable, high risk home settings, foster care, group homes, and custodial settings. And they're often very, very at risk of high risk behaviors. They have behavioral diagnoses. And they've also got high conflict mental health diagnoses, so lots of ODD, they tend to get into fights a lot, they tend to take a lot of risks and do impulsive things. So they're even more risk because of that. So I consider them the canaries in the coal mine. Currently, across the country and in the provinces, there are no standards of care for intervention, screening, education management, or substance withdrawal treatment in custodial settings for youth. It's something I've kind of been slowly chipping away at. And I think that custody, whether it's for youth or for adults, is often a missed opportunity for education and intervention. That's more of a plug for that part of things than anything else. And just as I said, the young man told me that after he went into withdrawal, he was offered by the correctional physician, which I think is very rare. So that physician must be doing this prescribing in the community to be comfortable doing it. In northern communities, as I said before, they're also, like, one size does not fit all. They're diverse, they have unique needs. If you go to Hay River or Fort Smith, which are south of the North Slave region, which is where Yellowknife is, I don't think I have a map, but I love maps. Then you'll see a lot more, for example, opioid overdose, opioid use, whereas if you go farther north into the Sawtooth region, where I spend most of my time now, you won't see much of that at all. You'll see a lot of crack cocaine use and alcohol use, and the overdoses tend to be accidental when the crack cocaine comes up from Vancouver and it's contaminated with either hydromorphone or fentanyl. They don't always know which one. What people want up there, and I'm not speaking for all of them, but I'm certainly speaking for the 8 to 10 communities that I attended a community gathering with, is to reduce rather than diversify the substances that they're seeing. They've already had to deal with cannabis and alcohol, and now they're feeling they have to deal with more drugs. And the idea that we're going to prescribe more abusable drugs, as they call it, is not something that's very appealing to them. They want to see measurable reductions in their losses to the community. And the communities are really, they're trying to overcome European influences, and in my opinion, if they want to decide how to manage these problems, and they don't want things like opioid tablets coming into the community, or even crack pipes. It's very hard. It took a while to even get naloxone kits accepted until they started to see overdoses and we started to talk more about it. But they don't see harm reduction. It's not welcome. It takes a lot of discussion to help them filter out what is useful harm reduction, what perhaps is not evidence-based. And so more regulation and safe drugs, in their opinion, of prescriptions is not going to do their communities well. I'm not going to get into that case, and I just wanted to mention that what's common in youth in custody and in the north, what's common to both of them, is you often see people with much higher ACE scores who are very unfamiliar with harm reduction and very resistant to it. There's polysubstance use because people are using whatever shows up on the next flight. It may even just be alcohol, but it might be alcohol and a bit of crack cocaine or a lot of crack cocaine. And there's a lot of novelty. So there's a lot of risk-taking and novelty-seeking and a lot of boredom. There's many other social issues at which these communities are trying to address. And the last thing they want to see is the infiltration of more new drugs they have to worry about. So far, there's not very much fentanyl in the Northwest Territories. It's actually very much like Europe in a way. There are no physicians prescribing short-acting opioid tablets. There's very few patients on methadone. Most of the patients with opioid use disorder are legacy prescription opioid patients, often who've come up from the south, and they tend to be on buprenorphine. And that's much easier to manage, obviously, in a dispersed community. And these communities, again, are very young and very inexperienced. This was a community gathering I attended in a place called Fort Good Hope in April. And I just asked, I had a table of 8 kids who were I was doing a naloxone kit training session with them, and I brought a bunch of expired kits, and they could open them and play with them because they were this black box with a red cross on them A lot of people were like, well, that's for a doctor or a nurse to open. So I said to them, no, open them and we're going to, play with them. When I asked them how many of them had, these are like 8 young kids between the ages of about 13 and 18. I asked them how many had ever used any drugs other than weed. They said none. How many had seen an overdose? Half of them. How many of them knew what to do? One of them, like actually knew what would be helpful to do. And how many of them worried about themselves or a family member? All of them. So eight out of 8 of them. And I just wanted to bring up this slide because it's a reminder that there are class action lawsuits now mounting against these programs that we do lack really solid objective evidence of benefit to young people. And these are 2 young women who were affected by diverted hydromorphone tablets. This is my goddaughter, and I put her up there because she's 27. I delivered her 27 years ago in Inuvik, and she and her mother have lived in Aklavik her whole life. Now, Aklavik is a very, very old community, used to be the center of the Northwest Territories, which is now in Inuvik. She and her mother have been there. I thought they'd be there forever. The grandfather lives there. They're looking after him. But this year, they had to leave Aklavik. They've moved down to where they're to like a kind of a drug-free or relatively drug-free community of other Indigenous people from their kind of region, because their next-door neighbor and their side-by-side had guns, drugs, and it was basically as if guns and drugs and a drug cartel was moving into this tiny community of about 250 people. And it's people like her and all of the thousands more that I worry about. She's an amazing kid. I hope she goes to nursing school. That's what she wants to do. I'm very proud of her, and so is her mother. And I think these are the people we can't forget. It's the people that won't ever be here. They won't ever, I don't even know if she's ever been in an elevator. So that's what we have to keep in mind. Oh, I mean, this is Dave.
More than enough time, more than enough time. Hi, my name's David McAvoy. I am a outreach worker in Ottawa. Won't identify the clinic I work out of, the place I work out of, because they don't like me speaking about some of these things. I'm dealing mostly, going to speak today about safe supply and the effects I've observed. Speaking to people, like I go into their homes, I see them on the street all the time. And, disclosures. None, other than where I work. The Safe Supply program, unfortunately, there was the law of unintended consequences reared its ugly head. And some of the biggest consequence I saw was the diversion of what was given out, the Dilaudid, the 8 milligram Dilaudid, DILs. And they ended up being traded. I speak to the fentanyl sellers. They didn't mind it at all. They said, great, it's something else to trade. It gives me another market to use. And many of them do send them away to communities up north or communities outside, smaller communities. They don't want to go there, but they know someone there. And again, it expands the use. And the reason I'm able to, there's always some argument over how much is diverted. Well, just on the most basic level, the costs. When I was using, and even after I stopped using, which was 15 plus years ago, the cost of a Dilaudid 8, if you could get one, was at least $40. Now, you can pick one up on the corner for $2. Do we know anything else that's gone down in price like that? And I think we can observe it's that supply, demand has driven that price down. Okay, we know the demand hasn't gone down. We know that the costs have gone down. So what's changed is that the supply has increased, which allows the prices to go down. And this, again, expands the market. And I'm going to give you an example of someone I knew, who I considered a friend. He was he'd smoke pot. He'd get drunk every once in a while. But he'd had a bad knee and bad back, and he just found, he was aware that, I can take these pills, pain pills, they're only $2 a piece. They're not dangerous, they're cheap. If they were 40, I have my suspicions of whether he'd even touched one. At any rate, as time goes by, about 2 weeks later, he speaks to me and tells me this. And I said, well, he says, I'm starting to feel very uncomfortable. I said, well, well, I tried to stop. I've gone off those pills. I think my back is better. And I recognize straight away when he tells me he's going to the washroom a lot, he's sweating a lot, can't sleep well. I said, brother, you're feeling a little bit of withdrawal right now. Don't worry about it, it can be handled. And I aided him through that. Sadly, it didn't work entirely. Now, he's dead as we speak here today. And I'm not saying he's dead because he went into full-blown fentanyl use. He didn't. But that opened him up into that world of, that very streety world that comes from opiate use. That need to get out there every day and get your thing. Kind of a sad thing. And we also know with the Dilaudids, I mean, it's nice to say we're giving people pills. Does anyone here really think any more than 10% of those pills get eaten? I mean, we used to laugh and joke about someone who would eat a Dilaudid. It was a waste. You injected it. So we're giving people these pills should be knowing full well that they're going to be injecting them and the corresponding problems. I mean, at least if you gave them some liquid hydromorphone, it'd be a little bit safer. And I understand that, we like to do the observed doses, but we know that the costs of that, and there's only so much resource. I mean, we managed to do it with the methadone, worked fine, didn't it? But now, somehow, we're going to give out these 30 Dilaudid a day. They'd have to be observed how many times over a day to actually do it effectively? And I'm just telling you that, as we all probably know, you leave a drug addict with pills overnight, his drugs overnight, he's going to use them very quickly. He or she, pardon me. And the other thing with the cost going down is, you can think of like kids out at a party on a Friday night, high school kids. If they, were at the party and someone off the side, a guy over at the side, he was selling a pill for 20, 30, 40 bucks. What do you think the chances of them actually trying that pill are? But $2? What the heck, I'll give it a try. Once you've opened that door, you've increased the risk. I'm not saying every one of them, but you've opened that door, you've expanded that market. To the extent, and I'll speak a little bit more about the markets, because I was speaking to one fentanyl dealer the other day, and I was telling him what I was speaking about. He says, yeah, I've heard that the Safe Supply program is going to be, they're going to be cutting out the Dilaudids. He says, I'm hoarding them now because I know the price is going to go up. I mean, these people are not, they're not stupid, they're market savvy. And, he was very proud of this fact. I have to admit, I thought it was pretty smart of him to be doing that. Pardon me. But, I'm not against, when I speak about this, as I said, I got in a little bit of difficulty at work because there was this belief that I was against harm reduction or I was against some way of reducing the problem. And I said, no, that's not it. I'm just saying that the way we're doing it right now isn't working and is creating side problems that no one expected. And just because you speak out against it, the format, doesn't mean you're against the concept. It's just a matter of fine-tuning the delivery methods. There's lots of ways to look at it. Anyways, I'm not going to take up much more of your time. Thank you very much for allowing me to tell you a little bit of my experience and what I see daily, nightly. And if you want to see it yourself, go hang out in front of a pharmacy that's near a Safe Supply place at 9 a.m. any morning of the week, and you'll watch the trading going on. Thank you very much.
I'd like to thank all the panelists for very stimulating presentations. Unfortunately, we only have 5 minutes left for questions, but I'm hoping that the panelists will stay around during the break, and if people want to come up. I'm going to ask one question, and I'm going to sort of summarize it because a few people have asked variations of it. And if people, somebody touched on the idea from the CSAM recommendations that it's the importance of the pharmacological intervention and opioid use disorder that's most essential. I think all of us understand the importance of that. But many people have asked the question, given that we conceptualize addiction as a biopsychosocial, spiritual condition, and many of our patients started on opioid use disorder in an attempt to address either physical pain or psychological pain, thank you, and many have trauma backgrounds. It seems a bit counterintuitive to many in the audience that having more psychosocial interventions in conjunction with pharmacological interventions would be perhaps lead to better outcomes.
You said counterintuitive?
I may have misspoke. Intuitive, that it would be better outcomes.
Yeah, I think CSAM completely missed the boat on that. What they didn't address is the fact that provider empathy and the relationship between the patient and the provider is absolutely key to the success of the program. And that's not just with opiate agonist treatment, that's been shown with chronic pain treatment, that providers who are rated higher on empathy by the patients, their patients with chronic back pain have better outcomes. And provider empathy has also been shown to be important for treatment retention. So just to say that it is true, maybe, that having formal psychosocial programs grafted onto an OAT program may not, it's hard to show the benefit because a lot of patients may attend. But I can tell you there's very strong evidence from the addiction field that if a therapist or a physician or whoever, NP, has a strong relationship with that patient, shows empathy, is listening, is advocating for them, working hard, it's going to make a difference for the outcome. And it's just preposterous to think that the whole benefit from OAT is just the drug. We know that that's simply not true.
So again, I'd invite you to join me in thanking our panelists, and I know there are many questions, so if people want to come up, you can have some FaceTime with our speakers. Thank you so much for attending, and enjoy your break.